I can't hear you. Sorry. Can you hear me? Can you hear me? Okay.
Can you hear me? Can you hear me?
I can't hear you.
How weird. Rosie, can you hear me?
Oh, I can hear you now, Mike.
Oh, okay. I don't know. Apologies. I'm just going to, afternoon, everyone. I'm Mike Grocott. I'm just going to go around the call and make sure that we can all communicate with each other. So Martin, we've just spoken. Christina, can you hear me?
Yeah, that's fine. I can hear you.
Thank you. Rosie, you're muted.
That any better?
That's perfect. Thank you. Hywel?
Yeah, I can hear you.
Brilliant. And Nicola?
Yeah, I can hear you.
Brilliant. And if we've got anybody else? Yeah. Simon?
Hi, yes, I can hear you.
Excellent. And Visha, sorry.
Is it Vishaka?
Vishaka, sorry.
I can hear. Yeah.
Hi, Vishaka.
Yeah, hi.
Great. Okay. Welcome, everyone. Excuse the Zoom interruptions. Thank you very much for submitting your posters and for coming along to this session. It's somewhat new ground for us at EBPOM to be doing this whole process virtually. So Monty Mython and I have done about 4 of these a day for the last couple of days. This is the second to last one. And it's been remarkably enjoyable, which is not to say I don't normally enjoy abstracts, but it's actually very different in the online forum. So interested to hear your comments and reflections at the end of this session when everybody's had a chance to present. I'll screen share in a minute. We've put together a PowerPoint presentation with all the different slides within it. So I can't tell you the order, but your slide will come up and then I'll give you a moment or two just to get your thoughts together and then we can start. And everybody has 6 minutes. And what we've generally been doing is having a short talk through of a summary of the results, and then maybe 1 or 2 minutes for that and 4 or 5 minutes to have question and discussions. But that's kind of up to you. If you talk longer, you get less question and discussions. Now I'm going to try the screen share, which hopefully will work. And you should see simply a single slide saying EBPOM abstract poster forum 1 to 2 o'clock. Everybody got that?
Yep.
Good. And can you see the slide or can you see the screen share view?
Screen share view.
Screen share. Yeah.
How's that?
Slide now.
Excellent. Okay. So a couple of introductory comments. Thank you very much for submitting. This Zoom call will be recorded so that we can put online the presentations and the discussion that takes place. So if you don't want that to happen, please let us know and we won't do it. And we can put that alongside a PDF of the presentation that you submitted. So you and others can access it over the next few days. The conference, you probably know, but just to recap, so the pre-recorded lectures will go online from Saturday morning and they'll be available to view from then onwards. And then the main program, which is Tuesday, Wednesday, Thursday, which is predominantly panel discussions, will go live on those days. And the Tuesday being a joint meeting with POETS, the Pre-operative Exercise Testing and Training Society, Wednesday being pure EBPOM, and Thursdays joint with CPOC, the Centre for Perioperative Care. And so we had about 120 posters, the 6 selected finalists. And if you are a selected finalist, you will know about it because we've been in communication and had confirmation from everyone. will be in 2 sessions on Wednesday and Thursday, I think during the afternoon. So the prize finalists are on those days, but everybody has done really well to get selected through to this point. So thank you very much for that. I guess the only other thing to say is that the whole new experience for us of running a virtual meeting rather than a face-to-face meeting means that all the different meetings we run around the world, so we have a meeting in Chicago each year, we have another one on the west coast of Ireland in Dingle, and we have one in Las Vegas now, will essentially be similar. So you don't have to go to Las Vegas to submit an abstract to Las Vegas anymore. So we will basically stitch those together into a program that tries to be complementary for each course. And if you do all of them and register that through our e-learning platform, at the end of the year, there'll be the opportunity to have a certificate of perioperative care relating to doing all that. So that's just really for your information. So if I move to the poster presentation bit, if I give Dr. Vishaka a moment to compose herself, and then if you just let me know when you're ready to go, and we can start.
Yeah. I think I'm ready.
Excellent, thank you very much.
Yeah.
Off you go.
Okay. I'm Dr. Vishaka Kerner from Sri Lanka. I'm presenting practical issues in optimizing cohort of pre-frail and frail patients with end-stage liver disease in North Colombo Teaching Hospital. So we studied 63 patients attending liver transplant clinic in North Colombo Teaching Hospital, which is one of the leading hospitals in the country. And it's found that end-stage liver disease is evolving and it's getting worse every day. The numbers are getting high. So because of that, the liver transplant needs going up. So we try to study one of the most important issue in these patients, which is frailty. So we use the liver specific frailty index, which was introduced by Dr. Nicola Kelly, and and also we try to evaluate their exercise tolerance with 6-minute walk test, and also we did the quality of life assessment with the SF36 score. And our results were out of our cohort patients, 31 patients were having diabetes, and most were child B cirrhotic patients, and larger number of patients, which is about 54%, were alcoholic cirrhotics, and one of the most complications we found was portal hypertension, which was 89%. And so we try to correlate this finding with the original study, which was done in USA. So, this was not studied in South Asian countries. So because of that, we redefined this score with 20th and 80th centile to be the cutoff for robust pre-fail and fail individuals. So we found that it actually the cutoff has shifted to the right side. So we found that there was the cutoff for robust was 3.61 and fail was 4.61. So and also we found that there was a significant correlation between the negative correlation between the frailty and exercise tolerance, which actually shows that this frailty index has been effective in evaluating the patient's exercise tolerance in our cohort of patients as well in Southeast Asian country. And also we try to study the quality of life index with SF36 score, and one of the key findings was that out of these 8 specific scores that we found in the quality of life index, when we compare the robust pre-frail and frail group, we found that there was a significant difference in the role limitation due to physical health and role limitation due to emotional health. So because of that, it shows that frailty actually affects the quality of life. And overall, all of our patients were having low indexes for quality of life in all the, there was a global, reduction in the quality of life in all these patients. And also the other thing is, one of the significant findings of this study was that we try to give them dietary advices, as well as prescribed exercise regime, which is mostly home-based. And actually we found that we failed it. So that means about 12%, which is 8% was compliant with that in about 2 weeks time, and only 1% was compliant at 6 months time, which is actually a significant finding. I think we need to do more studies to see what is the reason for non-compliance, as well as the details of this cohort of patients with frailty in this continent of the world, which is Southeast Asia. I think we have to do a larger study to validate this score, as well as to find the accurate cutoff for this population, which is including India, Pakistan, and Sri Lankan continent. Yeah, thank you.
Thank you very much indeed. So
Yeah.
can I, the exercise intervention is interesting, and the compliance obviously was very low. Was that a hospital-based or home-based, or what sort of intervention was it?
Yeah, it was a home-based intervention because actually our hospital did not have a facility to facilitate a hospital-based exercise regime, but compliance was very poor. Actually, I would say that this only person who was compliant at 6 months was actually not a person who did exercise because of us, because he was doing it for long time even before we advised him. So he was compliant until 6 months.
And what if? So obviously it's home based, but they could choose to go to a local facility. What is the availability of gyms or other exercise facilities for these people?
Yeah, so actually because of the socio-economic background in our country, it's most of these patients are not able to afford a gym facility. So what we introduced was walking mostly, because actually it was very difficult for them to, for us to train them to do a difficult exercise, because then they would definitely not be compliant. So we try to follow up these patients with telephone interviews to make sure that they are doing it. But unfortunately, they have been not doing it, which actually led us to be in failure.
Yeah, it's an interesting chat. Everywhere home-based exercise is challenging, but right now with COVID and people,
exactly.
people stuck in their own homes, it's a particular issue.
Yeah, exactly. And I think it's important for us to study, because actually in our country, they do not walk well, and the dietary habits are completely different to European countries, because we consume less meat. So I think because of that, sarcopenia and frailty will be definitely a problem in our population. So I think we have to go into detail into this, and we should raise awareness in this subcontinent, and we should emphasize this fact that they are not compliant. And they don't walk to the, to M.E.R.I.T or train like in your country. I think that will lead for them to have very poor muscle mass. So that's a leading problem in our country. So I think we have to raise awareness among these medical specialties to pay more attention to frailty in our continent.
Right. Thank you very much for your presentation. Time up, I'm afraid.
Thank you.
We move on to the next presentation. Dr. Wall.
Hi, can you hear me okay?
Yep, loud and clear.
Well, afternoon everybody, my name's Rosie Wall. I'm currently a second-year orthopaedic trainee based in the West Midlands here in the United Kingdom. So today I'm presenting a relatively simple project undertaken in my first year of training last year, which we looked retrospectively at the quality of the operative notes we wrote in the orthopaedic department. So for those who aren't aware, there's lots of guidelines that exist about what should be in an op note, particularly from the World Health Organization and Royal College of Surgeons, plus surgical specialty specific. So the British Orthopaedic Association also issue some. And this is because the op note forms a key handover between the theatre and the ward environments. We also, as a separate but related project, undertook a small survey within the department between the nursing, physio and junior members of the team. And the vast majority of them admitted that, as in terms of the paperwork that came back from a patient from theatre, the post-op plan was the only real bit they looked at, because it was usually bullet pointed and very simple, and that's what they felt affected what they had to do. So in January of last year, we looked at 1 week's worth of op notes that were produced within our department, both elective and trauma procedures, which was 136. And we analysed them according to a pro forma that we'd created, collecting lots of information as to what was included in the op note as a whole, but in particular in the post-op plan, and whether this adhered to the guidelines. We found reasonable compliance, but not brilliant across a lot of key areas. So we introduced our simple plan prompt, which is, as you can see on the screen, A for antibiotics, B, bloods, C, does the patient need a check x-ray and their clips or surgical sutures, where should they be removed, D, the DVT prophylaxis, which is particularly pertinent in a lot of orthopaedic procedures, E, exercise and weight bearing status, and F, follow-up. So we introduced this prompt. This was taught throughout the stages of training in the orthopaedic teaching sessions, and we also put posters up in the coffee room where the op notes are usually written. And then 6 months later, again, looked at a week's worth of op notes to see if they adhered to the guidelines, and in particular, whether these features of the plan were included. And encouraging, we found that across the board, particularly these features according to the A to F prompt, our adherence to documentation of the patients requiring this post-op improved, and it improved significantly, in particular with the check x-ray and follow-up. Of note to say that, of course, not all op notes require a patient to have antibiotics post-op, although that is quite common in certain open fractures and arthroplasty surgery. So whilst we looked at 347 op notes, of course, not all 347 would have required antibiotics, so they were stratified as to whether that was indicated for that procedure. So in summary, we managed to improve the content of our op notes in line with the guidelines that exist with a very simple prompt, which particularly for surgeons in training, which is where we saw the biggest improvement in the quality of the notes, is of use. So if you move trusts, as we all do as trainees, you can take this prompt with you anywhere you go. Another small aside into the future is it's something we've considered would be of use across surgical specialties. So conversations with friends in surgery and plastic surgery and general surgery, CRP is often a very important follow-up marker in general surgical procedures. So C could be changed to CRP trend, or D for dressings in plastics. It could be adjusted, but for orthopaedics, it appears to work well.
Great, thank you very much indeed. Can you, I apologize if I missed it, but then the nature of the prompt, is it like a sticker in the notes? Is it an electronic record thing? How does it work?
No, we literally sort of started saying to people, oh, ABC, like think of your ABC when you're writing your op note. And so at the registrar and SHO teaching, we kind of put it up, a couple of weeks running, we put it up as the last slide just to remind people, when you're writing your op note, don't forget your ABC. And then we printed off some posters, just a couple next to the computers where the op notes are usually written in the coffee room, although they got torn down fairly rapidly. But yeah, it's simply the poster and telling people to consider their ABC when they're writing their op note.
Great, thank you. Are there questions from anyone else on the call? So where do you think you're going to go next with this?
Well, as I said, the second round of data was actually collected a year ago now. So in the first instance, we plan to see if this is still being used. One of the limitations we're aware of is trainees tend to rotate in our deanery August to August. So it might just be that the trainees were getting better. And so that's why the op notes improved. Again, I think it's unlikely because we've noted some people now write their post-op plans, particularly at that trust, writing A, antibiotics not relevant here, B, check bloods tomorrow, that sort of thing. So I suspect we'll still see an improvement, but it'd be nice to demonstrate that that has been retained. So the first plan is to re-audit it again as a third cycle to see if we've maintained that.
And is a trainee network involved in this?
It wasn't initially, but that's the plan because I've actually moved trusts now. I'm not based there anymore. So one of the new ST3s is going to be re-auditing it.
Is that somebody want to ask a question? Did I see a hand go up, or am I anticipating?
I was going to ask, are there any targeting of consultants? It seems to be that the trainees are getting this as part of their training, but consultants will be there writing a significant number of op notes. Are they targeted in any particular way?
So the consultants wrote about half of the op notes that we looked at. We've targeted the trainees more because we divided, when we analysed the quality of the op notes, those written by trainees were poorer than those written by consultants in terms of adherence to it. That's why we've targeted the trainees. But the consultants write their op notes in the same place that the trainees do. So the posters are up there, and the project was presented at the departmental QIPS meeting. So they all got to learn the ABC as well.
Great, thank you very much. That's 6 minutes. Great presentation. So the next one is Martin. Now you'll notice my name's on this, so I'm going to try not to ask questions. So please, can I encourage you to think about questions as we go through, please? If you're not Martin.
You can answer your own question. My name is Martin Knight. I'm an intensive care and anaesthetic trainee in the Wessex Deanery, and I'm going to talk about goal-directed hemodynamic therapy in surgical patients and a systematic review meta-analysis of the impact of this on post-operative pulmonary complications. So we know from several studies that major surgeries associated with significant morbidity and mortality. We also know that goal-directed hemodynamic therapy reduces post-operative morbidity, in particular infections and pneumonia. But what we don't know so far is the extent to which goal-directed hemodynamic therapy impacts on post-operative pulmonary complications. So our primary outcome in this meta-analysis was looking at the incidence of total post-operative pulmonary complications. And our secondary outcomes were the incidence of pneumonia, pulmonary edema, ARDS, and pulmonary embolism. And we also looked at the total amount of intraoperative fluid used. Our search was conducted up until January this year, and we identified over 18,000 titles. We were able to narrow it down to 66 RCTs with 9,548 participants. And we found a significant reduction in total pulmonary complications, a reduction in pulmonary infections, and a reduction in pulmonary edema. There was no difference in pulmonary embolism or ARDS. And overall, there was no difference in fluid use, but there was more colloid and less crystalloid in the goal-directed hemodynamic therapy group. The study was limited partly by significant statistical and clinical heterogeneity. The studies have been conducted over 4 decades. And it meant that we had to downgrade the level of evidence to moderate. So in conclusion, we're suggesting that goal-directed hemodynamic therapy be considered as part of surgical pathways, and it may have a role in reducing post-operative morbidity.
Thank you, Martin. So questions?
Can I ask, can you just explain a little bit as to what goal-directed hemodynamic therapy involves?
Well, it has changed over the years, but effectively it's defined as the administration of fluids with or without inotropes and vasopressors against explicit measured goals in order to augment global blood flow and hence oxygen delivery. So initially it involved the insertion of a pulmonary artery catheter on the original trials, and then subsequently minimally invasive, non-invasive, and esophageal Doppler have all been used to help identify where fluids would be required in an individual patient continuously throughout the operation. And the goal is to improve tissue delivery of oxygen and improve outcomes as a result.
Yeah, the reason I was interested, because I thought if it involves an invasive method of monitoring, are there any associated risks with that? But then you've mentioned that, there's some methods that are a bit less invasive, perhaps. Yes,
I mean, there's complications with pulmonary artery catheters, so pneumothorax or pulmonary artery rupture, rarely, esophageal Doppler, esophageal perforation. And then the minimally invasive techniques that involve central line or arterial line have fewer complications, but there are complications associated with those. There are some that work on bioimpedance, which are non-invasive, and some non-invasive pulse contour analyses that are able to generate a waveform from a finger probe. So those have very few associated complications.
Okay, well, thank you.
Martin, may I ask a couple of questions? It's Christina Beecroft here. I'm a consultant up in the wilds of the east of Scotland. I've got a tartan chair behind me just for effect. I hear the words goal-directed therapy, PA catheters and Dopplers with a degree of dread, as I actually started my anaesthetic training in York, where we did some of the early work, and I clearly remember nights on ICU twiddling esophageal Dopplers to try and get some numbers out of them. But that's by the by. My first question is, and I suspect I know the answer, why do you think more colloid was used for therapy than crystalloid in the studies? That because you accepted that that was a slightly unusual finding, a slightly unexpected finding. And my second is a slightly more topical question, which is, what do you think the role of this is with our current COVID pandemic and its known issues with pulmonary complications and the starting of planned elective surgery that we're all encouraging, we're being encouraged to do now? Great question.
Yes. In terms of the additional colloid versus crystalloid, the majority of the trial protocols involved colloid as the bolus solution. So therefore, by nature of of the protocol, they were given more colloid than crystalloid. And why investigators would choose colloid versus crystalloid is unclear. Perhaps historically there's a feeling that it remains in the intravascular space longer, but I guess once a protocol started with colloid as the resuscitation fluid or the intervention fluid, then it might be perpetuated in amongst other trials who use similar protocols. And in terms of COVID, that is a very interesting question. I'm not clear the impact of goal-directed hemodynamic therapy in COVID patients. We've got relatively robust screening tools and self-isolation before elective surgery that would hopefully mitigate any pulmonary issues related to COVID. We shouldn't really be operating on elective patients with COVID symptoms. And the emergency cases, I think it may have an impact, but perhaps not as much as we might think. And from my experience in intensive care, patients tended to do better when there was a liberal use of fluids rather than restriction. They tended to develop renal complications rather than worsening respiratory complications. So I wouldn't profess to have a great understanding of fluid dynamics in COVID, but it is a very interesting point.
Thank you. Thanks.
Great. Thank you. That's time up, I'm afraid, but thank you very much, Martin. Great presentation. Next one is Dr. Davis.
Hi there. Can everyone hear me?
Hi, Simon. Yeah.
Hi. My name is Simon. I'm one of the Pre-operative Medicine Fellows at UCLH in London. And one of my roles in that capacity is working in HACU, a critical care facility for post-surgical patients at Westmoreland Street Hospital. And anecdotally, recently working there, I noted a reasonable incidence of anemia post-operatively. And so this retrospective cohort study is looking at our pre-operative screening for iron deficiency and its management. So a few years ago, the Association of Anaesthetists released a consensus statement on this topic, which highlighted the increased morbidity and mortality with preoperative anemia and made a couple of key recommendations, which included potentially controversially increasing the target hemoglobin for females to 130 grams per litre to equal that of males. Emphasise the importance of investigating and treating anemia in all surgical procedures where there was an expected blood loss that was moderate to high. And in its article, it suggested a regime for iron replacement, which particularly depended on the timing between identification and surgery itself. So Westmoreland Street Hospital normally carries out major urology surgery. And since the COVID pandemic, it's formed part of the North Central and North London Cancer Hub response to this pandemic, which has incorporated several other surgical procedures from other hospitals which have been isolating. So it's now doing major gynecology and renal procedures, and remains a clean or a green site. And so I reviewed all patients who are having cystectomies, nephrectomies, and hysterectomies through a month period in May to represent high-risk surgery for each of those three specialties. And in each case where there'd be a reasonable expectation that patients could be losing blood with their pathology and present anemic to pre-assessment clinic. And so my primary outcomes were looking at the identification, the treatment and the success of treatment of iron deficiency anemia. And then secondary outcomes were looking at the time between identification and surgery and the route of administration of iron and patients where it was required. And so I reviewed 51 patients as a electronic note review retrospectively, 35 hysterectomies, 11 nephrectomies, and 5 cystectomies, and found that of the 51, a third were anemic pre-op, but of that third, just over half were screened. In that half of the third, 2 were definitely iron deficient on their iron studies, and of those 2, 1 was given iron beforehand. And although there was identified 9 days before, so 12 days before surgery, she received oral iron, and on the day of surgery she remained anemic. And so my conclusions were just that despite the guidelines in place and the known harms with anemia, there was still a failing in that regard. The third managed to slip through and our screening wasn't adequate.
Great, thank you very much. Do you have a feel for the transfusion rate in this patient group?
It was actually low. So I've got the data here, but only, I think it was only 5 patients received, no, just give me 1 second. Sorry, 6 patients were transfused, and 4 of them were anemic beforehand, but neither of them were the 2 that were identified as iron deficient.
And can you comment on so the time when you were able to know they were anemic, so when they first had a hemoglobin measured, and the earliest time that you might have been able to find out, as in when you knew they were going to have surgery and somebody could have found out? Like, you know, how close are you getting, how early are you getting in the pathway with this?
So it varied quite a bit. Some patients were listed for surgery or initially assessed months and months ago, but the median duration was 9 days. Right. So in this guideline, any patient who's having surgery within 6 weeks of identification of anemia should be getting IV replacement. If it was more than 6 weeks, 6 to 8 weeks, then oral would be a reasonable intervention, with the option of retesting after 2 weeks to see if there was tolerance and increase in their hemoglobin count.
But it doesn't sound like the oral was or the oral's a limited option for you based on that guideline.
Yes, and just based on the nature of the cases that we're getting here, where these are expedited cases, I think by May things were streamlined. The Cancer Hub was established in March, and I think there was initially a delay in some cases happening before these Cancer Hubs coalesced. But by May, it was all fairly streamlined. One of the issues, though, is that although we were doing 3 different surgical specialties, and 2 of them were from different trusts, and each trust was responsible for their own pre-assessment.
Sure.
And so the cystectomies were pre-assessed by our clinicians using our guidelines, whereas the other 2 were pre-assessed elsewhere, and it doesn't appear that was really reviewed by our site before they turned up with the notes scanned onto our electronic system.
Understood. Great.
Yeah.
Yeah. Thank you very much indeed. I'm afraid we've run out of time again, sadly. Next presentation is Dr. Kelly.
Hi.
Nick, go ahead.
My name's Nicola Kelly. I'm an ACCS CT2 trainee in South East London. And so today I'm just going to briefly introduce a project that I've been doing to look at the NELA pathway, so the National Emergency Laparotomy pathway at Guy's and St Thomas's Hospital. So we set out initially in autumn last year to look at the pathway, specifically the proportion of high-risk patients who were being inappropriately transferred to a level 1 bed following surgery, which was a best practice tariff on the recent NELA 2019 report. And then we wanted to try to improve pathways to reduce the number of patients who are proceeding to a level 1 rather than a level 2 or 3 bed. So we looked at 152 cases over a year-long period between October 2018 and 2019. And we found that about 77 of the 152 cases were deemed to be high risk. Of those, we had 64% of patients who had a pre-op NELA score calculated and documented in the notes. So many of the NELA scores I was looking at were entered into the NELA data collection, but had probably been calculated either and not documented or calculated intra or post-operatively. Of those high-risk patients, 7 of them, so about 9%, proceeded to level 1 recovery rather than to a level 3 critical care bed or OIR, which is our overnight intensive recovery at St Thomas's. And of those 7, 4 proceeded to go directly to the ward, and 3 were then stepped back up to a critical care bed. Of the unknown patients, 10 of those went to a level 1 recovery, 3 went to ITU and 1 went to OIR, so the level 3 recovery. And of the low risk group, we saw that 4 went to a critical care bed and 38 went directly to the ward. In terms of mortality, amongst our low risk group, mortality was 0%. In the high risk group, we had a mortality of about 14% and about 7.1% in the group that didn't have a score documented. So the NELA guidelines state that those who have an unknown risk score should be treated as high risk. So all of those patients should be going to a level 3 bed. So at the time of implementing changes to the pathway based on these results, the COVID pandemic hit. And so we're currently undergoing ongoing quality improvement work to try to adapt our pathways and make them effective in the kind of post-COVID era. So you can see the figure on the poster shows our new pathway that has been split based on the COVID status. We've asked that all COVID high-risk patients, so either suspected or confirmed COVID patients, are treated as NELA high risk, and that's based on some work done by the COVID Surgical Collaborative, which shows that there's a high risk of mortality in patients with COVID who have elective or emergency surgery, and that's a 30-day mortality of 23%. If in those who get pulmonary complications, mortality is up to 38%, and it's associated with an increased risk in those having emergency surgery. So in terms of the quality improvement work we're now undertaking, so we've got a new pathway that's just coming out, hopefully in July. All high-risk patients are now to be discussed with the ITU consultant to minimise the number of phone calls being made by the anaesthetic team in theatre. We've created a NELA-specific WHO checklist to ensure that the score is documented pre-op. And we're doing teaching with a kind of MDT teaching with both the nurses and the medical and surgical teams to highlight the issues and the importance of pre-op scoring. And we've also got an e-noting tool which automatically drags data related to the patient's bloods, OBS, etc., to automate NELA scoring, which would hopefully improve compliance. So yeah, any questions are welcomed. Any questions?
Great, thank you very much. Despite claims that money solves everything, the best practice tariff doesn't seem to have completely resolved all the issues that you had, but this work is moving towards it. Have you? I know some places have not allowed a patient to be booked for theatre without a documented risk score. Have you moved to that sort of level of draconian intervention?
Yeah, so we've been doing some training with the theatre nurses. So our system is that the patients get discussed with the theatre coordinator and also the anaesthetic SHO when they're booked. So we're asking now that the theatre coordinator prompts any patients who are on the NELA pathway to have a score calculated, and the surgical SHOs or registrars won't be able to book the case until that's documented and in the notes. And then the anaesthetic SHOs have been instructed not to go and do the pre-op visit to the patient until the surgeons have confirmed that the score is documented in the notes. So that's kind of 2 extra steps to kind of force the point.
Thank you. Any questions from others on the call?
Just in terms of those which still didn't actually end up going to an ITU area, apart from those side that just didn't have a NELA score documented, was there any other documentation on the anaesthetic chart at all to rationalise why they went to a level 1 area instead of ITU?
So it wasn't clear. I did look at the anaesthetic charts. I think in many cases that the NELA score was documented later or wasn't communicated at the time of surgery. So it was done on a kind of look at the patient, they look kind of all right, let's see how they go. Sometimes there was a discussion with the critical care registrar, so that's our CRT outreach team, intraoperatively, and the registrar would suggest, why don't you send them to recovery, we'll come and have a look at them in recovery and see how we get on, which obviously misses the point of getting them directly to a critical care bed. I think part of the problem is that many of our CRT registrars come from medical as well as anaesthetic backgrounds, so don't necessarily know what NELA is or understand the kind of pathways that we need to be using. So in addition to training with the CRT team, we've escalated that so that all patients will be discussed with the on-call consultant. We think that will have better outcomes anyway, as the consultant has a better overview of the bed status of ICUs in general. So it should mean that they can identify where the patient should go in one movement, rather than it going to the registrar, then further discussed with the consultant and then back to the anaesthetist, leading to lots of unnecessary phone calls.
Great, thank you very much. Apologies to curtail it there, but we're over time. Great presentation. Next is Dr. Beecroft.
Thank you, that's great, thanks. So I'm Christina Beecroft, I'm a consultant anaesthetist up in Tayside, and which is in the east of Scotland, about 50 miles north of Edinburgh. And we found ourselves in April 2020 in a position where the main teaching hospital in Tayside, Ninewells, was able to restart urgent planned surgery. And in keeping with many other places, we developed 2 pathways. We have an indeterminate pathway, which tests patients 72 hours preoperatively, and we have a pre-surgical isolation pathway, which isolates patients for 14 days preoperatively and then admits them to a green zone within our teaching hospital. We don't have the luxury of cancer hubs or of other hospitals in Tayside. We don't have a private hospital locally that we could use as a COVID-free area. So we've had to create a hospital within our hospital. And in that, we have a very, very limited theatre footprint, which is limited partly by the fact that we have other theatres that have been redeployed to cover COVID work. We have staff that are still covering COVID work. And so it's very important at the moment that we're doing surgery on the right patient, and it's the right operation, and it's been done at the right time. And it's already been alluded to by Nicola that a study that came out as we were developing all of this work showed that the mortality with elective surgery, if you develop a post-operative infection with COVID-19, is in the order of 20%, which is a significant mortality rate, especially when considered in addition to the other surgical risk factors that you have with any operation. And so we really decided very early on in developing these pathways that we had to look very carefully at both our theatre pathway and our consent system. And I'll talk briefly about consent first. We start our consent process for these patients with a patient information leaflet that's given to the patients when they arrive in the surgical outpatient clinic. So before they even know they're coming for an operation, they're given a straightforward patient information leaflet that's been through our information governance service. And it starts to talk about the risks of perioperative COVID and also what we're doing to mitigate those risks and which of those two pathways patients might find themselves on. After that, the patients are seen by the surgeons in the outpatient clinic, and actually Julie Christie and Pete Ross, who did this with me, are both surgical consultants, and they have developed the consent form that I've put at the bottom of this. It's an extremely detailed consent form that is given in addition to our general surgical consent form, and it discusses the risks of infection with COVID-19 perioperatively, what steps we're taking as a board, as NHS Tayside, to reduce those risks, and also what might happen if you get it. So the fact that you might then need further tests, you might need to stay in hospital longer, you might need to isolate, and you might die as a result. The form had to go through the Scottish Central Legal Office, who were incredibly helpful, and it's now been approved by Information Governance at Tayside, and it's a Tayside document that's completed in surgical outpatients. We felt it was very important that patients consented at the time of surgical outpatients, because especially with a pre-surgery isolation pathway, you don't want patients dropping off that pathway halfway through because they haven't been fully appropriately consented for the risks that they're facing on that pathway. So we've tried to get that signed in surgical outpatients. But we've done a lot of other things as well to augment the consent. So we now have anaesthetists at every single MDT. So I sat on the vascular MDT for about 10 years, but anaesthetists are now on every single MDT, really to try and nip in the buds patients that really, I firmly believe that at the moment some patients shouldn't have surgery because the risks are so great. So we're trying to stop that happening. We've reclassified all our waiting lists now, which is a massive amount of work for our clinical leads, and that's been done along the new reclassification system from the Royal College of Surgeons, which is supported by our Scottish Government. And we have a clinical prioritisation group, which I sit on as the clinical lead for perioperative medicine, along with the clinical surgical directors. And the idea is, and this is lifted from actually a webinar from the AAGBI, but somebody said there's no distortion of priorities by those who shout loudest, and that's how we very much feel is we've got a really limited theatre footprint. What we need to do is make sure that the surgeries that are in the most need, the surgical specialties that need the theatre footprint are getting the cases done. So we've really tried to change our culture in Tayside so that surgeons no longer have their lists. And at our clinical prioritisation group, we have someone from waiting lists there, and we take the responsibility of changing the theatre footprint to make sure that the right patients are getting their operations at the right time. And that's really all I had to say.
Great, thank you very much. Really interesting and certainly topical. My main question. The clinical prioritisation group, so I've talked to other centres where they have this, and one of the problems can be that the different surgical specialties do as you described, and shout louder. I know some people deliberately don't put the heads of service on there because they're kind of conflicted, and they try and make it an independent and sometimes rather secretive group. How's it been with the heads of service there?
So we've got 4 clinical directors of surgery who've all actually established that the main sort of entirely independent person on the group is actually me as the clinical lead for perioperative medicine, because I have no waiting list to manage, I have no axe to grind, and so I think I'm seen as the independent person. We have a chair of the group. When the group started, it was made clear to all clinical teams that there was to be no canvassing of members of the group. I think you have to have senior surgeons on the group because I think that almost has to be there for the credibility of the group. But we also have a very clear governance structure, which is shown at the bottom right of the slide. And we have minutes, and the minutes are made widely available to all members of the hospital so that any decisions are very clearly seen. And actually, with having anaesthetists on MDTs, and with having a much better MDT process, and with recategorising our surgery, it hasn't been too bad. I have to say, and we haven't had many decisions challenged. What I have found is if you have P2 surgery now, that's inflammatory bowel disease, but not colorectal cancer. And the biggest sort of balance we're having to have at the moment is the fact that colorectal cancer cases are backing up in Tayside. They've just started scoping again, and we're getting lots of cases, and we're having to balance that against the fact that someone with inflammatory bowel disease is on paper actually more of an urgent classification and should have their surgery more urgently. But it's bedding in, it's getting there.
Great, Thank you very much. I'm afraid we're out of time again, but thank you. The next presentation, which also happens to be the last one, is Dr. Rawlins.
Good afternoon. My name's Hywel Rawlins. I'm a CT2 anaesthetic trainee in Ipswich Hospital in the East of England.
And I'm Megan James. I'm one of the anaesthetic registrars also in East of England.
And our presentation really is looking at the implementation of a new and novel MDT, certainly for England and the NHS, which is the Mobile Emergency Response Intubation Team, and again in response to COVID-19. And these came about as a response to China implementing them originally, and then NHS England recommending in their care of critical care COVID-19 patients that these were also implemented within trusts within England and the NHS. And we're specifically going to look at how we implemented it within our DGH at Ipswich Hospital. The initial role for the M.E.R.I.T team was to provide low aerosol generating intubation for critical care patients, but it actually expanded quite quickly to incorporate also attending cardiac arrests, trauma calls, and also assisting with COVID theatre cases too. This was only really made possible, obviously, because of the cancellation of elective lists. We had quite a significant redeployment of staff that wouldn't have actually otherwise had work to do. So we had a whole implementation of a new COVID rota and allocations of these staff to the M.E.R.I.T team, as well as secondment to intensive care. And they had a process by, they had their individual aerosol generating PPE allocated, a whole week of simulation training so that we were particularly slick at COVID intubations to reduce aerosol generation. And they also went through an occupational health questionnaire screening to ensure that they were safe from a personal point of view and that they are a low risk staff group. Now, we looked at the whole period that our M.E.R.I.T team were active, which was from the 22nd of March through until the end of May. During that time, they had 91 calls, the majority of which were 56 critical care patients that required intubation, transfer, and admission to intensive care. It was a local policy that was decided that we would intubate in situ wherever the patient was, so whether that was ward-based or resus-based. So they'd be intubated in situ by M.E.R.I.T and transferred to intensive care. Again, as a patient safety aspect to the individual patient, the staff, and patients around them within the areas. So the 56 patients, the vast majority were actually happening in the first month of the time that we observed, which fits with the peak of the COVID surge. And certainly from looking at the ICNARC data, our particular hospital seemed to be hit fairly hard in that we reached 300% capacity of our level 3 beds at our worst. As well as this, they also performed other roles that the intensive care registrar would have done, such as intra-hospital and inter-hospital transfers, as well as providing additional support on the unit for roles such as proning and invasive lines. We found that there were multiple pros and cons to the M.E.R.I.T team. Obviously, the most significant benefit was that it offloaded the intensive care staff from a significant amount of work. And it also enabled that we were to maintain appropriately skilled and trained airway staff on the intensive care 24 hours a day. And in fact, out of hours, we almost managed to triple our anaesthetist cover overnight because of the redeployment of staff. We also managed to result in significant upskilling of staff that were redeployed onto the M.E.R.I.T team. So ODPs and such that were particularly just used in theatre were redeployed to intensive care, and the M.E.R.I.T team got a completely new experience. One of the downsides, particularly from our point of view, was that we found that we were actually de-skilling in terms of aspects that we would have been performing ourselves as intensive care juniors and registrars. So attending cardiac arrests, attending trauma calls, and the ward intubations would have been roles that we would have otherwise undertaken. And we found that we hadn't done these for several months. However, overall, in summary, we found that it was obviously a significant benefit to us and was a complete necessity during the peak of COVID-19. But the workload in terms of intubation admissions for intensive care has dropped off to the point where we don't believe that certainly a 4-person team is necessitated to keep going, but it certainly provided us with a significantly positive structure to implement a team similar to this again in what will inevitably be a further pandemic in the future. Thank you. If there are any questions.
Great, thank you very much. One question for me is that when you say a standard operating procedure, did you adopt, as many did, a kind of standard recipe and standard intubation routine with a plan A, plan B, plan C being largely the same for each patient?
Yes, so prior to the M.E.R.I.T team going on call, a lot of simulations were run for the M.E.R.I.T team to run through a low aerosol generating intubation. A lot of these guidelines were taken from other countries. I think particularly Singapore had released quite a few guidelines around low AGP intubations. So the main aspects of that were that video laryngoscopy was used as a first choice intubation, and it was always the senior anaesthetist, whether that was a consultant senior registrar that was performing airway tasks, and then you had your junior registrar delivering drugs to try and reduce the time between induction and intubation as well. In terms of transferring the patient from the location where they were intubated up to ICU, we had plastic cover sheets and rules about non-disconnection of the ventilator circuit to the tube as well, to try and reduce that AGP aspect of it.
And did you, because we started not bag valve mouth ventilating, and we had some quite interesting hypoxia episodes, and then we started ventilating, but you know, cautiously avoiding you know, in patients who are paralysed, and for us that's felt a lot more comfortable without obvious substantial increase in risk. Did you end up following the same route, or did you manage to preserve oxygenation?
Yeah, so we use low flows for pre-oxygenation, and then we'll ask not to use BVM in between induction of drugs and intubation to try and reduce that aspect of it. But yes, like you say, a lot of these patients were starting off with saturations in the 60s and 70s already, so there was moments where it was quite uncomfortable.
Yeah. Any questions from others on the call?
Can I ask a question? Was there any incidences where you received 2 calls at the same time? So in that case, what was the backup plan?
So the backup plan essentially resorted to what the pre-COVID situation was, which usually the ITU registrar would be the person that would attend these emergency intubations, whether it was on the ward or in ED as well. So if there was a second call, the ITU registrar would have to leave intensive care and attend that intubation as well. We had upskilled or recruited more people onto ICU during COVID, so we had usually around 3 trainees on ICU at any one time, so it did leave people up on ICU if the senior registrar had to leave at that point.
And we're one of the rare hospitals, I think, where actually we don't have the funding for an ODP on our emergency bleeps. So quite often we're used to going to emergency intubations or cardiac arrest without an ODP with us. And the redeployment of theatre ODPs to intensive care was significantly positive, because it actually meant we had ODPs around that we could potentially borrow it when it came to this 2 calls at the same time occurring, so we could have a second ODP coming with us anyway.
Great, thank you. I apologise, but we're out of time. Thank you once again, everybody, for your presentations and the commentary and discussion. Any comments about the format, good, bad, indifferent, either now or by email later, but any commentary now? What do you think?
I think, can I make a comment? I think it's really nice that, I think it's much better than the pre-COVID situation. I would say that I think it has given us an opportunity by this COVID pandemic to participate in an event virtually. Even though it's done in London, I think it's a great opportunity for the people around the world to join and participate. I think it's really nice. I think this organization, everything was perfect.
Thank you.
Can I just say it's actually very nice to present your poster. So I've gone to numerous meetings where I've stood next to a poster for a couple of lunch times with people coming and peering at it and walking away again, which might just simply be a reflection of my posters. But that is something that I've experienced. And it actually is very nice to be able to talk about your poster to people who are vaguely interested in it. So thank you. And it's nice to get to EBPOM as well for once.
Good. And so one question, if there was more audience, i.e. we had some people who are muted but might be able to throw in some questions by the comments route, would you mind if it wasn't just the sort of select group of 6 or 8, but there were more people who happened to be interested?
I would like that.
Yeah.
Yeah,
I think
That would be better.
Okay, great. Well, really appreciate the time you've taken. I hope you manage to join us next week for as much as you can, and well, hope to meet you face to face sometime. Bye bye.
Very much.
Bye-bye.
Thanks a lot.
Thank you.